Thank you, Sanjay. It's true that I work in the hospital that was part of George Floyd's extended family. And so, although we are here to talk about the coronavirus pandemic and the old entrenched pandemic we have in the United States that took George's life is now intertwined with the new one. That is the starting point for my current experience this week, and so I apologize for the rather subdued presence that I feel like I already am just by joining. This is a somber time, and boy, the interface of the two problems together is really, really weighing on us a great deal in our hospital. But I'm still very grateful that I'm able to be back home in northeastern Pennsylvania remotely this way during this time to talk with the community of people who are still close in my heart, even though the pandemic has made it so I haven't been able to be home in quite some time. And I do wish that I could be, for sure. So thanks for having me. That hospital that I work in is a level 1 trauma center in the heart of downtown Minneapolis that takes care of some of the most disadvantaged people in our country, really. We are an urban center like many others, and there are areas of our cities where people have very little in the way of resources, and there are hospitals that have always been dedicated to taking care of them. And so although our hospital doesn't have a big flashy academic name attached to it, I'm really proud to be part of the operation there because of who we see. And so that relates to why we have to take both of our pandemics that have now converged on us this week so seriously. I am deeply troubled by the fact that the protests conducted the way that they have been, and the breaking of our physical distancing that many people have embraced to try to stem the tide of the pandemic is now going to make things even more difficult. Not to say things weren't already difficult, but you see, just like a lot of folks on the news are talking about how the protests are harming the very community of the people who have been harmed by Floyd's murder, that terrible irony, that irony is going to boomerang back as well, because those who have underlying health conditions, who have not received good health care along the way before they are exposed, as you know from previous iterations of this activity, are those at higher risk of suffering a greater burden of COVID disease and more likely to really end up in a terrible way by contracting the infection. Well, who are those people? They are the friends and close contacts of many of the people who are on those streets. And so we're very frightened about what's going to be facing our hospital soon. We have done a very good job comparatively in Minnesota to flatten our curve, and it's a marathon, but our populace up to this point recently had embraced it. And so although our numbers of cases had been growing, and you see on those maps on CNN that Minnesota is always red, meaning our cases are increasing, but they're increasing tiny bits each day because we're in the middle of the country and we were exposed later.
Yeah.
What that meant is if we took it seriously early, we were able to make a major difference in how things were going. But now, of course, we're not so sure that all of those early efforts are going to hold. And in fact, we're really more sure that we're going to be facing some trouble.
Yeah.
So that hospital, that level 1 trauma center, is almost like a mini city in itself. It doesn't have that many beds compared to a lot of medical centers you've heard about. It only has 440 total spots for patients to be in. But it has all of the bells and whistles of everything available to try to take care of the sickest patients, from burn specialists to the highest technology for cardiac and pulmonary support. And that kind of a hospital has to have psychiatric consultants who are available to help with the mental health needs of people who come to the hospital for other reasons. And that's what I do. So consultation liaison psychiatry is the subspecialty of psychiatry dedicated to assisting patients whose primary problem at the moment is not necessarily a psychiatric one,
Mhm.
and also assisting the doctors, the medical teams, and the nurses and the other folks around those patients who are in that moment having a really terrible medical or surgical problem and need psychological support, need expertise in the biology of the mental experience of being sick, and assistance for how really even care teams get along. You know, the more complicated a patient gets, the more conflicts there are about what the right thing is to do, and the stress is hard on doctors and nurses,
Yeah.
and they don't always treat each other well around patients, and everybody can feel the tension. And so that's what our job is to be not only experts on the ground, but also be a kind of container for some of the difficulty that hits the hospital. And I
Yeah.
have to tell you, despite all of what I'm rambling about the hospital experience, the thing that troubles me the most is by the numbers, our service has been a little less busy over recent months, not more. You might think it would be more total numbers of patients, but it's actually less. So why is that?
Yeah.
Well, the flattening of the curve and the real push to try to keep patients away from hospitals unless they absolutely need to be there. That's a message that our folks have gotten in our community. And in some ways, that's a very good thing to try to preserve the hospital space to not infect anybody else who needs to be, who doesn't need to be exposed already, right? So we have had fewer total patients in the hospital recently. We've done that intentionally. And then because of who those patients have been, they haven't come with their standard difficulties that we see regularly on our consultation service. What do I mean by that? I mean lots of drug overdoses, purposeful ones with the intent of ending one's life, accidental ones because of addiction, lots and lots of psychosocial problems that are part of our day-to-day life. For many reasons, those patients are not coming to our doors. But many of those people are homeless. They have very few resources. I worry about them a great deal at a distance, but they're just out of my reach. I don't get to be with them the way that I used to be. Now I have a different cohort of patients, and we'll talk about what the COVID experience of being in the hospital from a psychological standpoint is. But I just want to acknowledge that because the whole landscape of public health and approach to this situation has changed things, there are communities that used to benefit from having the hospital almost like a second home, a safety net for them when they needed a place to be, when they needed shelter, when they needed to escape domestic abuse at home, when they needed to address hunger, when those basic needs. The hospital is one of those sanctuaries, but they're not permitted in now the way that they were. Our doors are more tightly shut to those kinds of problems in the interest of doing better by the pandemic management, which is not a bad thing intrinsically, but there are consequences.
Yeah.
So the work in the hospital has changed. Also, the experience outside the hospital has changed. The other thing that's changed is, I've changed. Like, this is the way that psychiatrists dress now when they work in hospitals. I'm
Yeah.
wearing a strange scrub outfit, which I'm sure those of you who saw the advertisement were expecting somebody in a bow tie and some patched jacket or some weird thing like that. Maybe I should have a cigar at least while I'm. But this is the outfit, right? Because we're trying to stay clean, even though we have to be right up in the in the spot. And the last thing that I would say about being right up in the midst of this in the hospital is we're sensitive to the reality of limited resources. It is difficult to be close to people the way that we used to be. Some of our cases where we assist, we pause for a moment and wonder, should we as psychiatrists, who aren't technically essential to save the physical life of the individual in question, should we be burning personal protective equipment when there's a shortage of it because our standard routine of going into the room, sitting down and being present and being close to other people's bodies is no longer allowable in the same way. And so since it isn't, then we wonder about the best way to go about it. People don't see my reactions to their reactions the same way anymore because I'm covered. I was tempted to actually show up and have my first appearance here on the webinar be covered the way that I'm covered in work. and use that as a sort of strike way to talk about how this doesn't feel like psychiatry, and probably what you wouldn't expect from your therapist or someone who is really supposed to be attuned to your human experience. And that is really that's troubling to me. I do not like operating this way when I depend on so many other ways of communicating other than just words that are shared through a mask like this in a way that you can't really hear, let alone all the other things that are supposed to be shared. And so there are technological interfaces where some consult psychiatrists like me work through an iPad, or will talk to their patients on the phone and look at them through a glass window. I've done some of that work sometimes too, until we got our PPE scaled up enough where I could be deemed an essential person to wear it. I did consultations like that, and that is painful for me as I watch the pain of being alone in the hospital. Not to mention the aloneness that comes from separation from family, which of course you've seen in stories all over the news. The missing family at the bedside is something that really weighs on all of us, because we learn as psychiatrists to treat people as part of a family system, as part of a social network of relationships. We don't just take care of individuals if we're doing it right. We're thinking about how they're seated in their world, but now they've been extracted from their world and dropped into an ICU, and they're having a terrible time, just as their families remotely are having a terrible time.
I want to pause here because I want to synthesize a few things, and then
Sure.
we had a long conversation the weekend before last in an open office hour. It was the first of the kind where I'm inviting just professionals, and we don't have an audience. As you know, you and I spoke for almost 2.5 hours, and you related to me, as a professional and as a colleague, your experience over the last 4 to 6 weeks, including losing a patient to a suicide, while the patient was under your care in the hospital setting. I don't know if the patient was necessarily under your care specifically, but I'm saying in your hospital. And you just talked about how a lot of the surrounding society or community that would normally come to you for other care needs has not had access to that opportunity because of the circumstances. And one of the things that John and I do is try to provide reasons for people who have a lot of questions about things that they hear in the news. And one of the things that people have been hearing in the news is that hospitals are mostly empty, and 70% of ventilators we're using only 30% of ventilator capacity. And so all of the fear mongering that was early on about how this would overwhelm our healthcare system, was really unfounded. We'll get to another question later on about whether we overreacted, but in your estimation, and I'll allow Karen to ask a kind of a synthesis question that she and I put together before the show, that really melded together 37 different questions that came from people who wanted to speak to you, but definitely wanted to hear your answer, even if they couldn't make it tonight. So Karen will ask that. But is there now are we now creating a backlog of care needs unaddressed, that that you're going to have to, and specifically your community in psychiatry is going to have to deal with? Is there a surge behind the surge when it comes to what people will require of you? And before you answer that, the second part of my observation here is, you talked about how these patients, many of them may have to spend time on a ventilator. They can't even communicate their fears or their emotional state. And that has presented a new challenge. A lot of these patients have heard that this is a killer, and that if they end up in the ICU, there's an 80% chance they won't leave alive. Or even if they are coming in with a mild or moderate course of disease, fever and flu-like symptoms, they're coming in with a great deal of fear about the outcomes. and their families have a great deal of fear. So I guess just to hit pause and give you some framework to talk about what it's like dealing with these patients to start with, and then obviously the outpatient scenario that you see as an impending need once things, well, I don't know when, but once things start to change when it comes to the response to this disease.
I think that the way that you've asked the question really does highlight the key pieces of it, and so I'll really just kind of pick those up again and sort of relook at them in an answer and try to be fairly succinct. Different levels of experience really are vastly different when it comes to trying to figure out how to be most helpful. Sometimes it can feel almost dismissive to some patients to be struggling with symptoms, present for a test, have it return positive, and get the news from their treating physician, whoever interfaces with them, that they do indeed have an exposure, and what they are feeling physically is due to being infected. But because they don't have a need to have oxygen in order to sustain well, because they are stable enough to be able to eat and drink and basically care for their own bodies, they're dismissed in the acute hospital setting to go back home and asked, begged, to expose as few other people as possible in quarantine during that time, during recovery. And even that experience, although that's actually the good outcome in terms of the physical experience and the threat to life, that is different from much of people's medical experiences up to this point, right? You get this very threatening and anxiety-provoking news, knowing that it's possible that you could progress to serious disease. But in that moment, you're told, we're not going to have you come into the hospital because there's potential that you could progress to that disease. We are intentionally going to turn you back to go home and have you decide whether or not you want to pick up the phone again or call back or come back or let us know what's going on. And most importantly, go home and endure it alone. This is new in the experience of medical care for most people who have been patients before. And if they haven't been patients before, forget new, this is disheartening. This seems like it's not care. Like, wait a minute, so this is what it's like to be a patient with this? I know that that's strange to say that, but I'm trying to speak to more of the human psychological reality of the experience rather than clinicalizing it and saying, well, I can tell you all the reasons why these patients come to the hospital, these patients are on observation status, these people go here. We can talk about the medicine, but how about the human experience of having all that worry and getting that really horrible news of, yes, this is positive. Now go and contain the entire experience yourself.
Yeah.
At home, for the sake of society and for the sake of all of the rest of us and the beds in the hospital and this and that. Even though that is the least critical version of COVID disease, right?
Yeah.
That you know, there's asymptomatic, right? People carrying it around, but
yeah.
if you have any manifestations of disease, you, in that case, you go home and you endure it alone. And that's, you know, of course, we've been told that is the largest percentage of people who do become symptomatic. So what does that mean for our mental well-being? We are being told intentionally to go be alone, not just be alone in the service of us protecting each other, but now you've got the disease, but go be alone. Go suffer alone. Go nurse yourself. Don't be with somebody else to have support. I mean, think about the human animal in our societies. For so long, we've gotten used to sickness behavior and like, oh, don't we love it when our wife makes us chicken soup? Don't kids love it when they get tucked in by loving parents when they're having a terrible stomachache? None of that anymore.
Yeah, the care experience is broken down.
Not one, but very little of that. So even though we can talk about the higher levels of sickness, and you know, we can chat about the ICU experience and the hospital experience itself, I just wanted to highlight the fact that the majority of people who suffer with COVID and the psychological effects don't come to see me in the setting where I work.
Right.
Go back home and they have to endure it alone. And their contacts with the world are just like the ones that we're having here at best.
Yeah. So one other point that I want to add to that observation is that when you send them home, I think this is the wrong strategy. This is from, my background is in decision support. It's in population health and data. So I look for patterns and I look for reasons for good outcomes and reasons for bad outcomes. I mean, to simplify it. So I think that this is really bad strategy, not just from your perspective of the psychological need for care in a care setting, because that's what we do in a hospital. That's a care setting. And an ideal care setting involves the care team showing compassion, empathy, and involvement in the process of healing. That's absent. Okay, that's absent in this disease right now because of the keep them out of the hospital thing. All right, and then they're going. I don't trust these people. I'm sorry, I don't trust that they are not going to go and try to get what they need, or they have in the past 4 to 6 weeks left their home to go get what they need because they don't have a care team around them. Okay. They don't have the resources to have someone look after them through the worst of this disease. And I don't doubt that is not an insignificant, how we use the word, not an insignificant mode of transmission in the community. They're not in the hospital being isolated from the community and being taken care of. They're not having their care, their psychological and physical care needs met. And doing it by themselves is putting themselves and others at risk for poor outcome.
Because they don't have options, right?
Yeah.
Because they have to choose between going without food and basic necessities or finding those on their own because no one else can do it for them. That is one of the key reasons why this illness differentially afflicts our disadvantaged people from the beginning, because we can give good, sound, general advice for all of us, right? Because we're all potential walking petri dishes equivalent to the virus. The virus doesn't care. It's thrilled that everyone is out protesting.
Right.
Right. But those different folks, then when you think about how their lives are set up and what their options are, vastly different in how capable they are to actually listen to the guidance. And it isn't largely through their fault. There are plenty of people to fault. And you and I, as you've talked about your social media presence, you're angry with folks who break the recommendation strategy when they don't have to.
Yeah.
See the other side of the coin with so many people who truly do not have another choice.
Right.
And cannot follow the guidelines.
Yeah.
Because we do not have a public health response that is set up to make this better. And so when we talk about these layers of difficulty, the thing that troubles me the most when you started our discussion this evening by highlighting that by many measures, we actually have failed in the United States to do this as well as we really needed to save lives.
Yeah. Now, one of the things that we had a couple of weeks ago, we were hoping, and it's going to be this Sunday, and JJ, you're welcome to join. Dr. Daniela Marasco from Italy has been sharing her experience as a treating physician in a hospital setting in Italy. And they took the opposite approach. The hospital became their piazza. They invited everyone to it. Get out of the community, come here.
Right.
And that's why you saw their system overwhelmed very quickly. Right? You saw that in Foggia and in other regions, Lombardy. So I wish I could pronounce those Italian names correctly. But anyway, so let's take a step away from hospital medicine and into the community for a moment, and then we'll come back to this.